Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. I hope you pick up a few clinical practice pearls as well as things that might show up on your board exams as well. That's my intention certainly with the podcast. With that said, all of these medications that I'm covering today, I'm covering 5 of them. I've covered in much greater detail in previous separate podcast episodes. So go search the specific drug you're looking for at reallifepharmacology.com, hit the podcast tab, and then you can search any medication that you're looking for. Definitely a no-brainer there if you're trying to study or prepare for a certain exam. And you want to brush up on a specific medication, go search at reallifepharmacology.com. We've got over 300 individual podcasts on individual medications. So definitely wanted to share that bit of info and remind you guys of that. While you're also at Real Life Pharmacology, snag your free 31-page PDF. Simply an email will get you access to that. And you can do that by subscribing at reallifepharmacology.com. All right, let's get into the medications today. We've got number 86 of the top 200 drugs, and that is Metronidazole. Brand name of this medication is Flagyl. It is classified as an antibiotic. It can be used to treat bacterial vaginosis, anaerobic infections, intra-abdominal infections, amoebas, and also has some activity against C. diff as well. It used to be the drug of choice. We've got some other agents that are have better success rates now, but that does remain an option if cost or other considerations are a problem for a specific patient. Mechanistically, metronidazole gets incorporated into the cytoplasm of anaerobic bacteria and is reduced by bacterial proteins to create a free radical, which interacts with DNA and ultimately inhibits synthesis and leads to bacterial cell death. So again, gets incorporated or integrated into those bacteria and causes damage to the DNA essentially. Adverse effect profile. One of the biggest things that I educate patients about, or that I've heard patients report significantly or on a relatively frequent basis, is an abnormal or metallic taste, particularly with the oral administration of the medication. We've got oral and IV available. So pay attention to that. That can definitely be problematic for some patients for sure. In addition to that, other GI effects are probably the most common thing I've seen reported: diarrhea, nausea. Rare adverse effects, you may see some skin type reactions, QT prolongation. Again, not incredibly common, but something to be aware of there. In general, metronidazole has kind of a wider therapeutic index, so that's a nice thing where we've got a good window where we're not causing side effects and we can treat the infection successfully there. As far as monitoring parameters, I mean, it kind of goes to say with any antibiotic therapy, obviously we're looking for those symptoms to resolve from the infection, whether that be, fever, achiness, discomfort at the location of the site there. In the case of C. diff, for example, obviously improvement in diarrhea and GI symptoms. So again, that's basically what we're looking to do with metronidazole in the monitoring and the use of this medication. All right, a couple of things with interactions I have to cover. So historically, metronidazole and alcohol, absolutely not. You should not use those together. In general, I tell patients to try to refrain from alcohol as well. They're probably not feeling well to begin with. But in general, I think it's best to avoid it. But the potential reaction that historically was reported was nausea and vomiting and a disulfiram type reaction. The data lately says maybe that's not quite so true, or there is some evidence supporting that the use of alcohol is okay with metronidazole. But again, if you've got patients where they don't necessarily need it or have to use alcohol while they're taking metronidazole, hopefully they can get by a week or two while they're taking metronidazole and not drink alcohol. So again, still kind of controversial. The latest evidence points to maybe not as big a deal as we originally thought. But I think it's important to pay attention to that and make note of that anyway. And then drug interactions, probably the biggest one, the most highly tested one I've seen is with warfarin. Metronidazole can significantly increase INR levels and obviously increase the risk of bleed. Okay, so that's really, really important. Last but not least, I did want to mention QTC prolongation. So using it with other antiarrhythmics or antipsychotics or other medications that can prolong the QT interval, we may have some additive type effects there. All right, moving on, we've got Levetiracetam. Brand name of this medication is Keppra. This is an anti-seizure medication. It binds to the synaptic vesicle protein, SV2A, and causes an alteration in the release of neurotransmitters that ultimately suppresses and leads to reduced seizure occurrence. As you could expect with most seizure medications, because we're kind of blunting that central nervous system, sedation, drowsiness, dizziness, those are going to be the most common adverse effects. And obviously this is a dose-dependent effect, so the higher the dose, you may get more efficacy on the seizure side, but you're going to likely run into more sedation and dizziness and fatigue. Some other rare things, some GI upset can happen. Headache has been reported. There is some reports of lower bone mineral density. So I think that's an important thing to think about. And then behavioral changes, mood changes as well, has been reported. Skin reactions, again, there's rare potential, but not a crazy common occurrence by any means. All right, so let's talk a little bit about drug levels with levetiracetam. Typically, getting to a specific target range, we generally don't do that with levetiracetam. We titrate the dose to the desired effect, obviously reducing seizure occurrence, and usually leave it at that. However, there may be certain situations, maybe where we can't get seizures under control, we're concerned about adherence, and we want to just get that baseline level to see where it's at. But again, much, much less important, and we really don't have a narrower target like we do for a medication like phenytoin, let's say, in managing seizures. So important to recognize that with the monitoring, and that's typically how levetiracetam is handled at this point. Drug interactions, so additive sedation, that's one that I pay attention to. If you've got opioids, first-generation antihistamines, sleeper medications, benzodiazepines, certainly they can have that additive sedative type effect. All right, moving on. Next medication is Colchicine. Brand name is Colchicine. This is an anti-gout medication, and it can certainly help reduce inflammation that's associated with gout. It does this by inhibition of beta-tubulin polymerization into microtubules, which prevents basically the activation of neutrophils to the site of inflammation. So that's how it kind of reduces the inflammation and it helps improve that situation. Adverse effect profile. Number one is diarrhea. It's the biggest thing patients complain about. It's most frequently reported in the literature as well. Definitely can happen with colchicine, and I've definitely seen this lead to the prescribing cascade as well, where we've added an anti-diarrheal medication. So important one to remember there. I have seen some other GI upset, some nausea, for example. Fatigue, some muscle soreness, achiness have been reported there as well. Monitoring parameters, obviously we're going to pay attention to gout pain. Is that, gout symptoms and inflammation improving? Patients with renal impairment. So kidney function, I think, is an important thing to at least have a baseline on. Dose adjustments may need to be made there, as it is eliminated through the kidney to a significant extent. So definitely pay attention to that. In addition, colchicine is a CYP3A4 and P-glycoprotein substrate as well. So we've got some interactions there as well. So amiodarone, clarithromycin, diltiazem, these are all, kind of classic CYP3A4 inhibitors that ultimately may increase the concentrations of colchicine. Next medication, number 89, we've got Olanzapine. Brand name of this medication is Zyprexa. This is a second-generation antipsychotic. As a reminder, antipsychotics competitively block dopamine 2 receptors, as well as 5-HT2A receptors. But again, the primary efficacy surrounding antipsychotics is typically that dopamine 2 receptor blockade. Adverse effect profile. So antipsychotics, have a wide range of adverse effects that they can contribute to. With Zyprexa or Olanzapine specifically, weight gain. This is one of the worst for weight gain. Definitely something that can come up on your board exams, BCPS, ambulatory care, whatever. Olanzapine is one of the highest risk antipsychotics for weight gain and metabolic syndrome. It's also relatively sedating as well. So that's important to note there. Certainly other adverse effects that are reported with antipsychotics in general can happen too. Extrapyramidal symptoms, hyperprolactinemia, for example. These are all things that can have QTC prolongation. These are all potential adverse effects of antipsychotics as a class in general. There is some anticholinergic activity associated with olanzapine. So in my geriatric patient population, I do pay attention to that anticholinergic burden. Are they already taking a bunch of meds that have anticholinergic activity? Are we going to make that worse? So that's definitely something to think about there as well. Alcohol in general should be avoided. Smoking of note should also ideally be avoided, or at least recognize if patients are changing smoking habits. It can actually reduce the concentrations or induce metabolism of olanzapine, so that's kind of a unique one. I believe that's through CYP1A2 induction. So any changing in smoking pattern could potentially alter or fluctuate the concentrations of olanzapine. So good one to remember there, of course. And then along with that, drug interactions, anticholinergic burden, that additive effect, as well as QTC prolongation effect from an additive state too. All right, last but not least, we have number 90. That is Dutasteride. Brand name of this medication is Avodart. It is a 5-alpha-reductase inhibitor. And by inhibiting this enzyme, we ultimately prevent the conversion of testosterone to dihydrotestosterone, or DHT. DHT is responsible for the enlargement of the prostate gland. So naturally, this medication is used for BPH, so increased prostate size there. Now, when we reduce testosterone-like activity in the body, or DHT-like activity in the body, that can certainly reduce libido and cause some erectile dysfunction. So that is one of the major complaints that you'll see in male patients taking this for enlargement of the prostate there. Of note, from a drug interaction standpoint, we do have some metabolism by CYP3A4, so there may be some interactions there to kind of pay attention to. And then last but not least, I did want to mention a couple of patient education points. So pregnant women should certainly not take this medication, of course, but absolutely should not handle this medication either, if at all possible, since it is associated with birth defects. So definitely one really, really important thing to pay attention to there. From a patient education standpoint, the last thing I wanted to mention was this medication takes a long time to work. We're talking up to potentially a few months for it to really show its benefit. And so that's a great patient education point, because patients may want to give up on it, saying, hey, my prostate, it's been a week, 2 weeks, my prostate symptoms aren't any better. I'm still having some of the same symptoms with, frequency and urge and some of those things that go along with that prostate size. But again, patient education, really, really important. It takes a long time for this medication to start to shrink that prostate and help improve symptoms, which is often why it's used in combination with an alpha blocker like tamsulosin, for example. All right, well, that's going to wrap up the podcast for today. Do me a huge favor, support our sponsor, meded101.com/store. We got BCPS, ambulatory care, geriatrics, tons of Amazon books that have been bestsellers, fun stuff from crossword puzzles to engaging stuff to case studies and polypharmacy education, drug interaction education. Tons and tons of resources there that can help you prepare and pass board exams, as well as just help you become better at medication management. So please go check that out. Support the sponsor, meded101.com/store. If you enjoyed this podcast, do me a huge favor, leave a rating review on iTunes or wherever you're listening. Also greatly appreciate the ratings and reviews on any books that you've purchased in the past. Certainly more positive reviews if you liked it. Help us get those rankings higher on Amazon, and obviously allows me to reach more people. So greatly appreciate that as well. Comments, questions, suggestions, certainly reach out to me, mededucation101@gmail.com. Or you can connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. I am going to sign off for today. Thank you so much for listening, and I hope you have a great rest of your day.